I'd now like to introduce you to Dr. Majid Kazmi. Dr. Kazmi was James's haematologist for his HSCT 7.5 years ago now. So we have great affection in our hearts for Dr. Kazmi. Please give him a warm welcome.
Okay, thank you, Alison, and thanks to AIMS for inviting me to come and talk. I managed to double book myself today, so I had to leave earlier this morning to give another talk in London. The topic of my talk this morning was artificial intelligence. Unfortunately, human intelligence let me down and let me double book myself. But I'm here, and I'm really glad to be here. I'm going to give you a little bit of I think I can indulge myself in terms of reflections over the last 15 years in the field of autoimmune transplants for MS, so HSCT for MS. So just really what I've learned over those 15 years. So I'll talk about my first transplant. I'll talk about the importance of patient power. And we've had kind of a bit of conversation this morning already about advocacy and patients having to empower themselves to get decisions made for them. And charities like AIMS have been set up with that kind of objective. And you could argue about whether that should have been necessary, but it is necessary. And, I think that's been certainly one of my learnings. I think we had a conversation today about medical profession working in silos, and we'll have a little bit of a discussion on that today as well in my talk. And that postcode lottery, that horrible term of, where you live may very much determine what kind of treatments are offered to you. I think one of the things I've learned, and again I'll discuss during my talk, is about matching expectations. So what is a clinician expectation of what is a good outcome versus what is a patient expectation of what is a good outcome. And unfortunately, they're not always completely aligned. I think, as was said this morning, not all transplants are the same. And that applies to HSCT for autoimmune disease. And there's a big learning curve for the medical profession and people who are undertaking this kind of work. You kind of go into it assuming you've done 100 transplants for leukemia and it's all the same. It is not the same. And where do we go next? So a little bit of my thoughts. Again, you've heard quite a lot already this morning about where we think the field is going. But where do I think we may be heading? So this is my personal history for transplants for autoimmune disease. The first one I did was actually for Crohn's disease back in 2005, my first transplant. But my first MS transplant I did was in 2009. And I've done my 100th transplant for autoimmune diseases in 2019. But the numbers have really increased in the last few years, just because of the publications, the work that's been done, and the awareness that has arisen from that work. And this is just, it's got one of my patients, but it's also got people you'll recognize, just highlighting that it's the patients who've driven this field more than anything else. And the stories they're sharing, the experiences they're sharing, has really raised awareness and raised interest across the world, really. But it's that has really maybe sometimes kicking and screaming brought the medical profession along. It's the patients wanting to know more about this treatment. And I won't labour these slides because you've seen them multiple times before today, but it's really about where HSCT sits at the present time in terms of efficacy. It is still the most potent and most efficacious treatment we have for multiple sclerosis. I think, Professor Burt already articulated that very well. I don't think there's anything out there. The evidence is there. Now, none of us are naive enough to think that will always be the case, but right now, as we speak, it is the best available treatment for MS. And hopefully trials like the STAR MS will show that. What this graph shows is what we've learned over the time we've done this in terms of what patients do best with this type of treatment, what diseases do best. And it's a real eye-opener. We label, as doctors, we're very good at putting everything into labels. We label autoimmune disease as one big label, and we label HSCT for autoimmune disease as one big group. But actually, we know our responses, and the patient responses to the different treatments varies. So the results I've seen in patients with Crohn's disease is nowhere near as good as it is with multiple sclerosis. And that's probably partly related to the disease itself and how it is triggered and the immune response and how it is perpetuated, but also probably to the technology that we use to deliver the HSCT. And we talked this morning about B-cell directed therapy, T-cell directed therapy. We don't fully understand the biology of all of these diseases and what is the most important component. This again is familiar to you. It is the real challenge with DMTs, which is we know that they can't halt relapses and reduce MRI lesions and make people feel better for a while, but ultimately the disease kicks on. Whereas if you can really reset the immune system, then you have a potential for changing the biology, the natural history of the disease. And that's really where all the excitement for HSCT has come. There's lots of work. Paolo Marraro, who I work with very closely in London, has published extensively on the immunology of the immune reset. And we can now tease out, we've got the tools, and that's part of the mechanistic studies that John mentioned earlier today as part of STAR-MS. We now have the tools to really start dissecting out the immune system and really understanding what is happening pre-HSCT and post-HSCT. And that will hopefully then allow us to get even better at changing our protocols, adjusting our protocols, and getting even better responses. This is the worry, isn't it, for patients with MS? It's you know, we present this as a ladder going up, but actually for most people it's a downward spiral going downwards, that they feel that they're going to get worse with their MS as time goes on. And you know, one of my biggest learnings speaking with patients very early on was the fear of the unknown. That was the thing that drove patients. Is most of us as humans, we can adapt to a certain level of disability, a certain level of stress in our lives if we know that's as bad as it's going to get. But it's the unknown and what's going to happen tomorrow and what's going to happen the day after that really frightens all of us. That's a natural human instinct. And that's, for patients with autoimmune disease, and particularly with MS, that's the biggest fear that drives them. We can all very well say, oh, yeah, MRI looks stable, but if they're getting weaker and not able to do the things they were able to do 6 months ago, a year ago, that is terrifying. We had a bit of conversation this morning about DMTs, and that, let's be honest, it's a multi-billion-pound industry, DMT. And so when you're competing with that, with a technology that isn't funded by a big pharma company, you're really competing marketing, awareness, embedding in every single neurology department. All of these companies are out there doing every single neurology department across, not just the UK, but across the globe. And they're talking about their products and they're educating about their products. Well, we don't do that for HSCT. We don't have that same reach at the moment for HSCT as a technology. And we just don't have the financial resources to compete. But that is the brutal reality why DMTs is still seen as the number one choice, even though all the data we've looked at would suggest otherwise. So my first patient, I explained, was done at Guy's Hospital in 2009. And I'll just tell you a little bit about this patient because there's a reflection there. He's a 29-year-old male who was diagnosed a few years previously with relapsed-remitting MS, but had really frequent relapses, really aggressive disease, and went from an EDSS of 2.5 to 8.5 within the space of 4 years. And was being fed by a peg tube and could only really move one arm. Was in a wheelchair. And basically the neurologist, Paolo Marraro, asked me if I could do a transplant on this patient. It was our first one we did. We conditioned it with beam ATG, which I don't even use anymore. A very aggressive protocol. And we did the transplant. And the patient, I've been following the patient up for over 10 years now, is still EDSS 8.5, but is alive, would be dead by now, has managed to have 2 children grow up, and is enjoying a certain quality of life. The issue is, I wouldn't do that patient now. Based on the data, based on what we've seen, that patient came to me tomorrow, I'd be saying no. And this just shows the MRI scans showing the resolution of some of those lesions that this patient had on sequential MRI scans. And what that's taught me is, as doctors, we don't know everything. We set criteria, we adjust criteria based on where we think the evidence lies most, but we don't always get it right. And I know there are patients here who have been turned down by us and have gone somewhere else and had their transplants and have done well. It's just a reflection. We don't know everything about this disease. We don't know everything about the way we deliver our treatment, and we're learning. And we need to be open-minded about the fact that we're still learning. I also think as doctors, we shouldn't impose our values on patients. And again, we sometimes do that, probably more times than we should, really. So what I mean by that is, what is important to me as an individual, as a person, as Majid Kazmi, may be very different to somebody else. What risk I'm willing to take for my health may be very different from what somebody else might take. And I've had those conversations with patients. You can talk to a patient and you can say to them, there's a 99% chance you're going to die, and there's a 1% chance you'll survive, and they may take that. And you can have another conversation with another patient and say, there's a 99% chance this will work, and there's a 1% chance you'll die. And they'll say, I don't want it. The 1% too high. It's too rich for me. So we have to listen. We have to listen to the patients, and we have to understand what is it that's driving them, and what is it that makes them want to make those decisions. What's most important to them? And in this field, when you're doing things like HSCT for MS, really got to listen to the patient. And Gavin and others articulated this morning, patients are not an MRI scan. You can't just say, oh, well, the MRI scan looks stable, you're fine. We'll see you again in a year. Patients, we're being disingenuous. And, one of the things that trust that you have between a physician and a patient can get broken very easily if they believe you're not telling them the full story. And if you're sort of saying to them, well, you're fine, and they know they're not fine, then you're breaking that trust. Papers have already been discussed this morning, so I won't go over it. But really what I talked about, my first patient in 2009, the next patient I think was done a year later, and then I didn't have another referral for about 3 years because there was just no interest. No one was interested in sending me any patients. These papers, the work that's been done by people like Richard and others, really kick-started, because the field in the eyes of the medical profession, they really started to say, okay, well, maybe we need to think a little bit more about this. And the numbers, and I'll show you some of the graphs, have really escalated for MS in the last 5 to 7 years since these papers came out. This, I tell you, I'll go back a long way. So I've been following the league tables, if you like, for autoimmune transplants. And John and I religiously went to EBMT meetings, and we'd be castigated why the UK doesn't do very many transplants for autoimmune diseases, etc. We're a big country, we're a rich country, lots of patients, why we're not doing more. So in 2008, we were doing about 100 patients plus for autoimmune. We'd done about 100 patients for autoimmune indications. And then you look at 2015, we hadn't done many more. You can see we were kind of still lagging behind. But what had happened is Italy had taken off, particularly around MS patients, started doing a lot more. In Germany, we're doing more for rheumatological conditions, but we were really not doing very much in this space. But over the years, and certainly since 2018, it's changed. And you look at this 2018 graph, we're now in 3rd place. Interestingly, Sweden was ahead of us. And Sweden's a much smaller country. Why is Sweden ahead of us? Because it got nationally commissioned. HSCT got nationally commissioned for MS in Sweden for patients who'd failed their first DMT. By the end of 2018, we were in 2nd place and chasing hard on the Italians. who are ahead of us. 2021, neck and neck now with Italy. The number of cases going for the UK significantly increasing, and almost exclusively MS. And then finally, in March of this year, big shout out to the UK. We finally became the number one centre in the UK, in the Europe, in terms of number of transplants we're doing for autoimmune. And that has been driven by patients asking for this treatment, driven by interested clinicians, Basil and John and others who've pushed this field in the UK. So come back to the power of the patient. And Mindy and others are in the room, often warn me about the forums that are out there for HSCT. I never look at the forums. I don't know what people are saying about me. Probably best I don't know. But what I did know was people were reporting what was happening, their experience with the neurologist, their experience when they're actually having HSCT pre and post. And this has driven more interest amongst the patients and more awareness of what's going on, what questions to ask your neurologist, what questions to ask your hematologist when you've been considered for this treatment. And that, again, we've seen that in many other disease areas now, but really in HSCT for MS, it's the patients' forums and the advice that's been given that's really driven it, and it's challenged the medical profession. And for a long time, the only two centres in the UK that would offer this treatment were Sheffield and myself at King's. It's now, in London, all the transplant centres, apart from the Marsden Hospital, which just does cancer, offer HSCT for autoimmune disease. And now, with Star MS and other centres are being set up. So there's more access now, and people are not having to travel as much. But I think this graphic just sums it up. Medical teams, we work in silos. I trained as a hematologist, Basil trained as a neurologist, and it's very rare. That collaboration is actually pretty rare. So when I was working at Guy's, my first patient for MS came from Paolo Morara, who was working at Imperial, because the Imperial hematologists were not interested at all in doing a HSCT for MS. So he asked me. So for a while, all the patients that I was getting, and my neurologists were not interested in sending me any patients. So it was a cross-hospital collaboration. And what we did with that is we built. And initially, we had an MDT, which was just myself and Paolo sitting in a room discussing cases. And that grew, and we had more neurologists and more hematologists joining. And now, when we sit together, and we've got our next meeting on Friday, there's about up to 20 people in the room. And there's from all the neurologists from all the major centres, plus all the hematologists from all the major transplant centres in London. And beyond, we have people dialing in from other places, including Ireland, who want to identify the right patients and want to discuss the treatment options for these patients, including HSCT. But it's still fair to say there is inequity of access. There's still some parts of the country where it's not even mentioned. Some parts of the country where people, I'm having a discussion with one of my patients who's here today, just yesterday or the day before. In Scotland, in certain parts of the area, it's not even not mentioned. It's actually told you it's dangerous. Don't even go there. You're mad to even think about HSCT. So it's not even just saying we're not going to talk about it. We're actually going to negatively talk about it and actually put you off even thinking about it. And that's just not acceptable. And I've always said, one of the things we have to do in the UK, and this model has been well established in cancer for many years, is create multidisciplinary teams with the right experts in the room. And so every region should have a team of experts, of hematologists and neurologists who understand all the latest technologies in MS and can have an informed conversation about whether the patient is suitable or not. You cannot have what we have at the moment. In some areas, London, we're fortunate, we're an outlier. We have lots of neurologists who've got lots of knowledge of HSCT now. That is not the case if you go into southwest England, etc. criteria is always a difficult one. As I said earlier, we don't get it 100% correct. What we're just trying to do is trying to give us the best risk-benefit profile, but it's not 100%. So some patients we will have turned down who would have done really well, and other patients we'll have taken on who perhaps we shouldn't have taken on. And that's partly driven by the fact that the criteria by themselves are limited, just based on the evidence we have so far. But also, one of the things I learned in learning in the cancer space is not all scans are the same. Not all tests you do are the same. Not all biomarkers that you look at are the same. When we talk about complete remission in cancer now, there are lots of different types of complete remission. You can define complete remission by finding one cancer cell in 1,000 and saying, well, if I can't see one in 1,000, that's remission. But other people can look at it now, 1 in 1,000,000, and say, well, if you can't find one cancer cell in 1,000,000, that is remission. So there are different levels of remission. You can imagine it's like an iceberg. What's below the surface, you don't really know. And so for diseases like MS, it's no different. There are, you can go into remission. The immune system can be changed a little bit, but have you really changed it enough to make that a long-term remission? And when you do an MRI scan, what protocol are you using? What kind of machine are you using? Does that really give you a really good insight into what's happening into that patient? Biomarkers, if we're using neurofilaments or whatever, what is our cutoff? What is our threshold? What is the validation to say, above this, you're too progressive, you shouldn't have it. Below this, actually, you will work. And one of the things that staggers me about a lot of my medical colleagues, and it's not being critical of them, because cancer has had some advantages over other disease areas, but cancer has spent a lot of time building up risk scores for patients, trying to risk stratify patients into who are the ones who are going to have aggressive disease, who are the ones who are going to have less aggressive disease. And we need to do something similar in autoimmune diseases, because again, we've all seen cases of MS where it's very indolent and patients don't get very much symptoms and can go 20, 30, 40 years without anything too much. And then we have the other group, within a year, they can end up in a wheelchair. So clearly it's a heterogeneous disease between individuals, and we need to be able to stratify patients much better than we're currently doing. Our experience so we've done well over 200 patients now, but this was a published experience. It was the first 120 we did. And I think it goes back to that conversation about expectations. So about half our patients had what would be classified as progressive features. But it's important that even when we define progressive features in our group of patients, we're still talking about patients who've got some evidence of either inflammatory activity on an MRI scan or clear-cut evidence of progression that's very quick. We don't take patients who are slowly progressing over 20 years. We don't believe that treatment really works that well for them. But in this group of patients who would be defined as progressive MS, we are still seeing benefits. Not as good as we're seeing in the relapsed remitting MS patients, we are seeing benefits, and certainly we're seeing stabilization for a lot of these patients in terms of their symptoms. And again, it boils down to what is the expectation of the procedure. And for patients, when you say, well, the best you can hope for is we'll just hold you as where you're at now, a lot of patients will take that. Everybody secretly hopes they'll get better, but everybody will take, at least don't make me get any worse. This quote, I think, is quite apt. One of the things I was faced with as a hematologist when we got into this field was, it's just a transplant, just another transplant. I can do it. I've done hundreds of transplants for lymphoma, myeloma. What's the problem? And then you realize how wrong you really are. And there are certain things, we've talked about some of these earlier today, there's certain unique things about MS patients that cause complications that a hematology unit that's never done one before may not be used to seeing. Infection. So most hematology patients are mobile. Most of them have normal bladder function. They don't have incomplete bladder emptying. They don't have a reservoir for infection or gram-negative bugs. MS patients can do, some of them. So you need to be aware of those things. You need to think about whether you catheterize patients pre-procedure just to reduce that risk. Autonomic dysfunction certainly is something I was less aware of when I first started doing these. MS affects nerves, not just the nerves that make your arms and legs move, but the nerves that make your heart function, your lungs function, etc. In the middle of a HSCT, when your body's under a lot of stress, fluids going in, fluids going out, temperatures going up, drugs going in, drugs going out, that puts a lot of stress on the body. And if your heart can't respond quickly enough, if your lungs can't respond quickly enough, then that can cause problems. And some of the issues we've had with the transplants we've done in the more advanced patients has been around autonomic dysfunction. We talked about the ATG, fever, seizures. So again, MS patients can get seizures. And I've had a couple of patients who've had seizures. In the middle of a transplant, when the platelet count is low, having a seizure is not a good thing. So you need to kind of be ready to maintain things like sodium levels and magnesium levels at much higher levels than you would normally do for other transplants, and think about prophylactic anti-seizure medication. Deconditioning is a big thing. Physiotherapy really is a really important part. Prehab and rehab is really important to stop people deconditioning after HSCT. I'll talk a bit about EBV reactivation and the role of ATG, and then the vaccination. This is a really difficult topic. We've seen, and I have seen cases of MS now after the COVID vaccine, etc., and I don't really know. I'll be honest. I looked at the data. I've seen what the recommendations are. It's really difficult to tell patients what's the best thing to do. Scientifically, there's not a huge amount of data to suggest don't vaccinate, but we've all seen cases where it's caused problems. And so, I have the conversation with patients, but I don't force them to have the vaccinations because it's a difficult one. So these are the kind of workup tests we do, but important things for this group of patients: fertility preservation, really important. A lot of my cancer patients have already been through lots of chemotherapy before they get to a transplant. That fertility conversation has happened a long time ago. Whereas MS patients, if they've been on a DMT, fertility has not been an issue. Now it could potentially be an issue, so you've got to have that conversation. And one of the things I learned when I was speaking to patients was some of them don't want to know because they're so worried about the future. They can't even think about having children right now. But what you have to get them to understand is, well, what happens if we stabilize your disease and in 5 years' time you're feeling well and now you want to have children and you haven't done something about it beforehand? So even if right now it's not the top of your list of priorities to think about it, just think about it, because actually if we get a really good result with HSCT, your view of the future, your view of what you want in your life may be very different. I now, for my more advanced patients, will do more detailed workup because I've been caught out a couple of times, particularly around the autonomic dysfunction. So we will do a more thorough workup, and sometimes we will turn patients down because we just are worried that they're going to run into trouble during the transplant. So we do more detailed respiratory workup, more detailed cardiac workup, and more close monitoring during the HSCT procedure itself because of the risk. So this is the EBV story. I think it is related to the ATG. We're currently looking at our protocols and our data, but what was a real learning curve for us is I've seen EBV reactivation in other autoimmune diseases, Crohn's patients, scleroderma patients. It's not a problem. It goes up, it shoots up, but most of them don't get PTLD, which is post-transplant lymphoproliferative disorder. Most of them don't even know they've got it. It's a different story in MS patients. When they get EBV reactivation, they feel unwell. And the first time when we started to see it, we got caught out. We didn't realize what was going on. We were using our standard protocols of waiting until they got a full-blown post-transplant lymphoproliferative disorder and then giving them some treatment for it, which is normally a drug called rituximab. It's only when we started to see some of these complications that we then decided we need to get in earlier. And so now we don't let them get to a certain level. We just start going in preemptively with rituximab. We're now reviewing our protocol, and the proposal going forward is to reduce the ATG dose and also to discuss building in a dose of rituximab into the protocol anyway, just to stop it happening at all. But it's a learn. a learning curve, like everything. I think it also reflects that EBV is intrinsically linked to MS in some way that we don't fully understand. 100% of patients that I've transplanted, all EBV positive with MS, whereas in the population at large, it's only about 80% will be EBV positive. So there's clearly some direct link between EBV and multiple sclerosis. And this is our updated data showing the difference between our incidence and what was happening at Imperial, and that was because of the difference in the ATG dosage. We're just about to put together our UK data set, which I suspect will show the same thing. So just to finish off, where do we go next? I think for me, improving the safety of the procedure. Yes, the mortality is low, but there's still a significant amount of morbidity, and we still could do better, particularly for the patients who EDSS is above 5. We need to just think a bit more about what we're doing. I think there's more to do around the efficacy. So our data would suggest, certainly around relapses, about 90% of patients don't get relapses after a HSCT. MRI, about 90% of patients don't get any new MRI lesions after HSCT. But progression, still only 70-80% of patients don't get any progression. So there's still 30%, maybe 40 if you're more advanced, where they are still progressing after HSCT. So what more can we do in that group, and what other strategies do we need to deploy? That part of that is around patient selection. And what I'd like to be able to do is select earlier patients who we know are not going to do well. And rather than wait until they failed 1 DMT, 2 DMTs, let's just get in there early. And I think that's the message you heard already this morning. Get in there early. And that's when you're most likely to get the most benefit for these patients. Huge conversations about remyelination and what can we do in that field. And there's a lot of work going on, a lot of interesting stuff going on, but there's still no licensed therapy for remyelination. But what you would be able to hope to be able to do for those patients who've got a significant amount of disability, if you get them early enough, you may not need to do anything about remyelination because you've done them early enough. But for those where there is a disability, then perhaps a nice strategy would be to do your HSCT, stop all that inflammatory activity, stop any ongoing damage, reset the immune system, and then give them a remyelination therapy 6 months, 9 months post-HSCT. And that may speed up their recovery. We won't know until we do the studies. And then there's a lot of excitement about the new technologies that are coming. And we're using these in cancer. So CAR T-cell therapy is a designer drug therapy. So basically, it's harnessing the immune system. So what we're doing is we're taking cells of the immune system out. We're programming them in the test tube, if you like, and then we're reinfusing them back. And we know that those cells can go back, seek and destroy tumor cells. But those same cells can also seek and destroy abnormal cells of the immune system. And so why can't we use that same technology in autoimmune disease? And there's some really good data coming through in patients with lupus, showing some really spectacular results in that group. And in our studies being planned for multiple sclerosis and other autoimmune diseases. There's a lot of interest in this, and surprisingly, the pharma companies now see this as a big market opportunity. So there will be, no doubt, lots of commercial trials and significant investment in this field in the next few years. I'm not naive enough to think that HSCT will be the treatment that's going to be standard of care in 5 years, 10 years' time. I suspect there'll be newer treatments, better treatments. But where we are today, it is the most potent and most efficacious treatment we have. But we should always be looking forward to what's coming down, what can be done better. Bone marrow transplantation has been around a long, long time. And it's a technology that's worked well. It saves thousands of lives for cancer patients, and it's made a transformative difference to patients with autoimmune disease like MS. But 50 years' time, people will look back at it and say, what were you thinking? This must, it seemed very primitive to what will be the latest technologies that will coming downstream. So with that, I'd like to give a big thank you. This is one of my patients who we transplanted a few years ago at London Bridge. And her ambition was she wanted to go rock climbing again after her transplant. She sent me a picture of her climbing a wall, 2 years after her transplant. I'd like to thank my team at London Bridge Hospital. A big plug, there's got a stand there, so please do visit their stand. But also my team at Guy's and King's College Hospital and the Pan-London group, all the neurologists, all the haematologists who are involved in that. But most importantly, the patients and the carers who looked after them, who really pushed this field and made, it is what it is today. Thank you very much. Happy to take any questions.
Thank you, Dr. Kazmi. What I'm going to do now is ask Dr. Elisa Roldan Galvan to come on, and what we'll do is at the end of her session, we'll have questions for both of you because she's moving on to talk about the CAR T cell therapy, which you finished on. So, Elisa, if you want to, can we give Dr. Kazmi a round of applause and a round of applause for Dr. Roldan Galvan. Thank you.
Hello, everybody. I'm a hematologist as well, working here in Sheffield inside the STARMS trial team. I work every day with Professor Sarak and Professor Snowden and learn from them every day. Today, I'm presenting this new topic that has been just introduced. Is what is a CAR T? Just an introduction of what is a CAR T, how we produce this CAR T and deliver the CAR Ts. Just a brief comment about the toxicity and which can be the role in the autoimmune conditions, specifically the role in MS. Sorry. So what is a CAR T cell? So you know that in the past decade or maybe 20 years, immunotherapy has become like a big pillar to treat the cancer patients by facilitating the recognition of the immune system to target the tumor cells and then enhancing the action of the immune system to kill and even eradicate the cancer cells. The key cell that organize all these response are the T cells that not only stimulates the rest of the immune system but as well kill directly the infected cells or the cancer cells. So this new type of therapy that is part of the immunotherapy called CAR T cells is just modifying these key cells, these T cells, to try to facilitate the recognition of the tumor cells. More or less in 2017, 6 CAR T cell products has been approved to treat different cancers in hematology, including lymphomas, including acute lymphoblastic leukemia or multiple myeloma. It's been proved as well in lymphoma, in CNS lymphomas, and some recent experience has been used thinking that these specifically trained T cells might have a role in autoimmune conditions, as well as he was mentioning before, by targeting these autoreactive cells that are driving the disease. So what is a CAR T? CAR stands for chimeric antigen receptor, which is a receptor that is specifically engineered to give T cells the availability of recognizing a specific protein. So if we put this specific receptor in the T cell, we get this CAR T, and what is going to happen? This is going to enable the T cell to recognize the target cells or recognize the cancer cell or the autoimmune cell and proliferate and expand inside the patient. So the basic structure, this is changing all the time, and there's much more complex CAR T cells now, but the basic structure has 3 domains. One is the target binding domain that allows CAR Ts to recognize the target molecules. It has as well a co-stimulatory domain that enhances the growth and survival of the CAR Ts inside the body of the patient, and about that these CAR T cells are going to die. And there's an activation domain that activates the CAR T and produces all the inflammatory and stimulatory reaction. So how do we do this CAR T cells? So we start taking the these lymphocytes from the patient. We use the apheresis machine as well as we use it in the stem cell transplantation. We get only lymphocytes and we remove the rest of the blood back to the patient. We take these T cells and send them to the lab. in this lab can be somewhere. In Europe, usually is in Amsterdam, but can be in the US as well. In the lab, we alterate these T cells genetically to specifically show this receptor, and when we get these CAR T cells, we grow these CAR T cells to have millions of these type of cells and being able to infuse back to the patient. We need to give some chemotherapy before the infusion of the cells. This is what we call lymphodepleting chemotherapies based on fludarabine and cyclophosphamide, and is given to prepare the patient to eliminate the lymphocytes and to prepare the patient to receive the CAR Ts. And then we infuse the CAR Ts as we do for a transplant, so an IV infusion or for a transfusion, really. The problem is CAR T cells has a specific toxicity. That's the reason why we need to monitor the patients, so we cannot give the chemotherapy, give the CAR T, and send the patient home. We need to monitor the patients to ensure that there's no specific toxicities. There's two important ones: cytokine release syndrome, immune effector cell-associated neurotoxicity syndrome, which is a very complex name, and no one calls it that way, and everybody calls it as ICANS. And there's other specific toxicities, but probably as hematologists, we are more used to deal with them, such as infections or reduce of the blood counts, etc. So I'm only gonna go through these two initial one, the cytokine release syndrome. This is an acute systemic inflammatory syndrome characterized usually by general symptoms. The key symptom is going to be the fever, and then it can produce multiple organ dysfunctions. It's associated with CAR Ts, but can be produced in any other immunotherapies. It can happen in bispecific antibodies, so it happens as well in some specific type of transplants. And what happened? So the CAR T cell, we infuse the CAR T cell, and these CAR T cells targets the tumor cell, and this produces a pro-inflammatory cytokine release. So this has like a lot of messages saying the whole immune system, the whole cells in the immune system, that they need to start the inflammation and they need to start to kill these specific cells. But sometimes it's so effective, so good, that it produces this exaggerated inflammatory reaction. So as we were mentioning, the symptoms are going to be basically general symptoms: fever, low blood pressure, low saturations, tachycardia. These are our more important symptoms that we're going to follow. The good thing is now, as hematologists, we know very well how to diagnose this syndrome, how to give the supportive care that we need. This supportive care sometimes might need to be in an ITU unit, and we have a specific treatment called tocilizumab that treats very effectively this cytokine release syndrome. There's all on scale to grade the level of the cytokine release syndrome, and we usually use the tocilizumab only in specific situations, but I'm not going to enter in all of this, just to mention that we have a good treatment now to try to control this cytokine release syndrome. And what is ICANS? ICANS is basically the same as CRS, but when it happens inside the CNS. So it's a neurotoxicity syndrome that can occur days or even weeks following the administration of the CAR Ts. This is a key thing because the CRS usually happens just after the infusion of the cells, so 1 to 3 days after the infusion of the cells, but the ICANS can happen even 10 or 14 days or even longer after the infusion of the cells, so we always need to be very careful on this. The pathophysiology is still not very well known, but we know that it includes the inflammation, so it includes interleukins such as interleukin 1 or 6. It is mediated by the disruption of the blood-brain barrier, and it produces endothelial activation and neuroaxonal damage. But we still need to know much more about it. The symptoms are very, very different type of symptoms. Headache is very common. Tremor is probably one key symptom. When the patient is starting to have grade 1 ICANS, it's very, very common to have just a mild tremor. Even we use some scales that we need to ask the patient to write down the same sentences every 8 hours or every 12 hours to ensure that it's not happening this little tremor or these changes in the writing. Disorientating disorders are as well very common. And then everything can happen, apraxia, aphasia, seizures. But this is like the more in later stages, let's say. So we are trying now to diagnose the ICANS in the initial stage, in the tremor or headaches, and try to give the treatment that is based in steroids as soon as possible to try to avoid these other problems. And why I'm explaining this? Because we know that it's really, really effective in lymphomas, in B-cell malignancies, and that lymphomas is basically targeting lymphocytes. And we know that in autoimmune diseases, the B cells has as well a key role. So why not using it to treat autoimmune diseases? So as I was mentioning, CAR T cells may be employed in the field of autoimmunity thanks to this availability to target a new specific antigen and boost the cell activation. The CAR strategy might have a benefit comparing with the monoclonal antibodies that we are already using. For example, it has a broader depletion of the B cells, and specifically it penetrates better in tissue. So you are going to penetrate better in the inflamed tissues and has more access to the lymphoid organs, comparing with the antibodies. So this is a very important advantage in CAR Ts. And some research experience has been published in lupus, as it has been just mentioned, refractory antisynthetase syndrome, or in systemic sclerosis, and all of them are really encouraging. I'm going to present, for example, some results in lupus. So there was 5 persons that were treated with for systemic lupus erythematosus that were already refractory to multiple therapies, and they were treated with an anti-CD19 CAR T cell. CD19 is a receptor that is in all B cells, such as it is CD20, that is the antibody such as sacralizumab, for example. So they give this CD19 CAR T delivered after the lymphodepleting chemotherapy that I talked about, and it was an improvement in all 5 patients. No evidence of disease activity and freedom of immunosuppressive medication was achieved after 3 months. So the patients were off of any other treatments after 3 months, and in the follow-up, in the publication of the trial, it has 8 months follow-up, and all the patients were still with no immunosuppression treatment. And even they have the B cells has reappearance, and the condition is were not happening again. And this is an example of one patient. As you can see, not only all the symptoms related with lupus improve after the infusion of the CAR T cells, but also the antibodies related with the lupus were negative after 44 days post-CAR T. So it's really, really interesting therapy. And the good thing as well is this was very well tolerated. Only it was a mild grade 1 cytokine release syndrome with no ICANS, so no neurotoxicity that I was mentioned. So seems like it's better tolerated than in cancer patients. And what do we have from neurological disorders? So a few experience with neurological conditions. 12 patients has been treated for refractory neuromyelitis optica. They were treated with a BCMA CAR T therapy. BCMA targets the plasma cells, another key agent in the immune system, and 11 of 12 remain in remission. Only one has a relapse after the CAR T cell infusion, but even this patient had a clinical improvement. The CRS was only low grade, so as well, very good results in this condition. In myasthenia gravis has had as well a recent publication, 12 patients that receive a RNA CAR T and show meaningful responses as well. Being an RNA CAR T reduced the toxicity, so no patient has CRS or ICANS, which could be as well a good strategy. And as you can see in the images, we are already changing all the options. We have in the upper part of the image a standard CAR T that targets the B cell in general, but we can use what is called CAART, which is like putting a specific autoantibody receptor. So we are not targeting any B cell, but we are targeting specifically the receptor of the disease. And there's other type of modification of the cells that is being explored, like for example CAR-T-Rex, that tries to suppress the inflammation. So many things can be done based on these results. Other clinical trials in different neurological conditions are worldwide open, but we are still pending on results. And the role of CAR-Ts in MS, so it's difficult because we don't have data yet, but we all know that B cells drive drive the disease in several mechanisms: antigen presentation to the T cells, production of pro-inflammatory cytokines, and as well being resident in the central nervous system. And we already know that targeting CD20 is useful to treat the MS, although it's not a long-term solution. So maybe targeting B cells through this CAR-T cell therapy is going to be more effective and could be a very promising approach. And why we think it could be a potential benefit, because it's selectively target and modifying the defective in the immune system and confirm a long-term or even permanent remission and eliminating the need for ongoing immunosuppression as it happens with the lupus patients. As I was saying, no patient yet with the MS population. There's a lot of interest and a lot of clinical trials that are still in early stages in development. It's been mentioned in different talks today. It's not clear in which setting we need to use the CAR-Ts for MS patients. There's a field that is very big to start research, but I think it's a really interesting field to discuss. And just as conclusions, CAR-T therapy is a new type of personalized immunotherapy that has revolutionized the B-cell hematological malignancies I was mentioning. It is produced by genetic modification of the T cells of the patient to target a specific cell. It has a very specific but treatable toxicity, CRS and ICANS. It has already shown good responses in other rheumatological and neurological conditions, so based on this common pathogenesis, this might have as well a role in some patients with multiple sclerosis, but trials are still awaited. Thank you so much.
Okay, I think we've got time for 3 or 4 questions for Dr. Roldan Galvan and for Dr. Kazmi.
And coming from a place and a technology industry, it is something that is prevalent across all technology industries, and hopefully the people in the room can grapple with that. But my comment is more in relation to its approach in Scotland. I'm resident in Scotland, and it was very sad as well to hear some of the comments from the 2 people at the front of the room, because today is my 4-year anniversary, having been treated by Dr. Kazmi in 25th of November 2019. And during that year, the same year in October 2019, the Scottish Technology Organisation gave a recommendation to the Scottish equivalent of NICE to proceed with this. We've read all the MIST papers coming out. I'm a long time since I actually had to digest all that information and do all of that technology learning by myself. But without the assistance of the neurology team within Aberdeen Royal Infirmary. So I'm just hoping, as we have more sessions like this, and for anyone who's in this room from Scotland, you know my face now, so you can find me. But equally, and I say that to the medical people as well, right? Make use, because one of the things that happened is that really the neurologist didn't make use of my experience. And I hope going forward they will. And thank you, Dr. Kazmi. I stand here today, and I too have photos of myself climbing, when I used to actually try and persuade myself I could walk 20 meters. I was 4.5 to 6 EDSS at one point. Now I'm close to 0. I work full time. I have 2 kids. I travel all over the world for my job. That's what I can do. So I am a dream picture. So let's get more people in Scotland to live that dream as well.
Thank you very much. to birth.
So thanks, Anne. And yeah, I was referring to you during my talk. But I think ultimately, I think as Gavin summed it up, it needs a lobby. You know, it really does need a lobby. There are patient groups out there who have successfully lobbied for things, and HIV is one good example, but there are many others. And it shouldn't be that way. None of us think that's the right way it should be done. You shouldn't have to lobby, but we are where we are. And it's still too slow, and there's still too many areas where this is not being discussed and not being offered. And we can't continue that situation. So I think it does require charities like AIMS and others, and getting commissioners in the room, I think, more than anything else, because ultimately, you know, we're providers of the healthcare, but actually we don't pay for it. It's the commissioners who pay for it, and we need to get them engaged in this conversation so that they understand what it really means to a patient to have MS. We can look at all the data, we can look at stats and Kaplan-Meier curves and things, but ultimately there's nothing that's more impactful than speaking to someone who's been through the procedure several years ago and can tell you what their life has changed to after that procedure.
Is it okay if I just make a comment and kind of food for thought? I think CAR T cell, is it working? I think CAR T cell therapy is great. There's definitely a future for it. It's had some good effect in the B cell lymphomas and in lupus. And I think using it in NMO, which is a B cell mediated disease that is anti-aquaporin 4 positive NMO, is a very good place to start for demyelinating diseases. However, a long time ago, when they started using an antibody to just B cells for MS, I wondered why. Why are they ignoring the T cells, which for me, I mean, they're all involved, but that's the more predominant effector cell, and that's how we adoptively transfer the disease in animal models. So using these monoclonal antibodies against B cells, you know, they shut off MRI activity and clinical relapses, and then many years later they appear, which is worse, this disability. And so I worry if you use CAR T directed against B cells, which currently they are, or if you're choosing a plasma cell, it's really an end-stage B cell, you will get the same thing as Ocrevus, is that initially you'll look good therapy for a few years, and then you'll have PIRA with all this progression because you have not treated the T cells. So I would just be careful using it in MS. I think NMO is a great place to use it. That is clearly a B cell mediated disease, but I'd be careful in MS. And then in addition, the CAR Ts can give that cytokine release syndrome with high fever, and that can cause permanent neurodegeneration with worsening of EDSS later that you won't get with infusion of the antibody against the B cell. So I don't want to discourage anybody. There were a lot of naysayers when I started this. CAR T cells are great. They're going to have a great role in medicine, but I'd be careful starting in MS with it.
I mean, I cannot be in more agreement with you, really. It's, I think, starting with these conditions that has a specific antibody, and we know how it's working and how the pathogenetic of the disease is the way to go. That's why it has been done like this. And in MS, it's probably much more complex because the pathogenetics is much more complex than just a specific target. So this is something that I think all the people who has an interest in the field is aware, and it's not clear, and there's a lot of debate in which might be the good receptor or with the good target in MS because it's not very well known. So that's why I put it such as a positive role in MS, but not conferring a specific agreement or decision that this is going to work and for sure it's going to be the definitive therapy. That's not at all, because as you were mentioning, the pathogenesis of the MS is much more complex and has many other confusion factors that might have a different prognosis in this situation. So yes, I'm completely in agreement. It was only a 15-minute talk, so I couldn't enter too much on anything, but yes.
On that question, maybe only one additional information. Firstly, thank you very much for your report, but I absolutely agree with Professor Dr. Bird. We are developing CAR-T therapy for multiple sclerosis, and we also think that anti-B therapy isn't very effective for multiple sclerosis because this is T and B cell-related disease. So we are developing some approach to target the regulatory cell against such targets like myelin-based protein, to look deeper to mechanism of multiple sclerosis and to find appropriate receptor or target for this is future for CAR-T therapy. So I think only anti-CD19 or 20 therapy isn't enough here. We need to find something unique and specific from multiple sclerosis mechanism to look deeper. Thank you very much.
Again, in complete agreement.
So just as a follow-up on that, one of the problems with directing T-cell therapy specifically for MS is there's a concept called epitope spreading, and we've seen it repeatedly in animal models, and it's to what it's been looked at, it happens in MS. So once this T-cell activates against a particular small epitope of a particular protein in myelin, once that damage starts, it spreads to other T-cell with other T-cell receptors targeting other epitopes, even other proteins in myelin. And that's why it's very hard to have a specific therapy for MS targeting just a T-cell subgroup. The perfect place to go is NMO. Thanks.
Yeah.
Thank you very much. Can we give them a round of applause, please?
Yeah.